Alrighty, hello everybody.
Hi there, everybody. One second. My colleague Alson, I guess, is having some internet problems. So welcome to Wednesday webinars. My name is Chloe Felwak. I'm the communications assistant here at NHF, and we're pleased to present Dr. Lynn Malik today. She's going to be talking about navigating the emergency room with an inhibitor. So I will hand it over to you, Dr. Malik.
Great. Well, good afternoon, everybody. Thanks for the invitation to speak today. As Chloe mentioned, we're going to be talking about navigating the emergency room with an inhibitor. This is borrowed from some of the talk that I gave at the annual bleeding disorders conference. And it's really meant to be a practical guide to put a frame around how to navigate emergency care. So quick disclosures in terms of my work with some of the pharmaceutical companies. And then going through objectives for the talk today. So one is really that you as the patient or caregiver, if you're caring for someone with an inhibitor, will have an understanding of how the emergency room works. And how to best navigate the obstacles that are faced when receiving care. Also to be provided with information on how to effectively communicate their needs or your child's needs while in the emergency room. And then information on how to prepare in advance should an emergency rise. So we'll go through things in kind of a stepwise fashion, and then at the end we'll have time for question and answer. And before I begin, just a little bit about myself. I'm actually a pediatric and adult trained hematologist and serve as the medical director of our hemophilia treatment center here in Milwaukee, Wisconsin, which is part of historically named the Blood Center of Wisconsin, but now the Versity Blood Center. I really have a passion of taking care of patients really of all ages throughout the lifespan. That's one of the reasons I love the role that I have here in our lifespan clinic. And my areas of clinical research and clinical focus are especially on patients with inhibitors. So it's a topic kind of near and dear to my heart to think about how to manage care in the setting of a bleed or an emergency. So first, starting with kind of the behind the scenes look of how the ER works, and we'll go through, I think, some of the important things that are sometimes hard to understand from the patient side. So first and foremost is really kind of triage of patients. So typically in most emergency departments, the check-in of patients is going to typically be done by a nurse. And it's going to be done based on protocols at the institution, taking into account a few different aspects of the story. One's going to be kind of the route of arrival. So did you come in by car? Were you at your hemophilia treatment center and we sent you over to the ED? Did you need to come in by ambulance? So that will factor into some of the triage, as well as presenting symptoms. So what are the things that you're saying as the reasons that you're coming here to the emergency department? And then based really on that, patients are going to be assigned a triage level of care, sometimes also with initial vital signs that patients are then triaged in terms of kind of the level of concern for those symptoms. And I think one thing that is really key is that in patients with hemophilia, and especially those with an inhibitors, a bleed may not be obvious. So triage to be roomed directly may require some advocacy. So this is something that through the Medical and Scientific Advisory Committee, so the MASAC guidance through NHF, they help your providers and your care team remind those doctors and clinicians taking care of patients, as well as patients themselves, the idea that the bleed may not be obvious, there might not be external bleeding, and that is something that really will often require some advocacy to get across. So then let's think about the providers in the emergency department. So some of the truth is that the providers that you're going to be seeing in the emergency department may have little or really no experience of a patient caring for a patient with hemophilia. So all will have learned about bleeding disorders at some point in training. However, really there's no guarantee that they've cared for a patient with a bleeding disorder, that they've cared for a patient with hemophilia, that they've cared for a patient with hemophilia and an inhibitor. Often, you would be seen by a physician in training, a resident or a fellow, if you're at an academic medical center, before that supervising doctor, which we call an attending, comes in. Just as a quick kind of reminder or tutorial about the training. So outside of medical students, all of the levels of trainees, of residents, fellows, they all are doctors. So they completed medical school and they would be going on in the setting of a resident to do pediatrics training. So they could become a pediatrician, or internal medicine training. So they could become an internist. And then a fellow is someone who's chosen to go on to do extra training in the hemophilia space. This is typically like my training in hematology oncology, that you go on to be specialized in that field. And then, as I mentioned, that supervising doctor, the attending doctor, really has the resident and fellow under their care. I kind of mention this because often it can be confusing, kind of like, why are you seeing multiple doctors or student doctors, or kind of who's the care team that you're going to be seeing. Part of why I also mention this is, by nature of trying to get to the bottom of bleeds, oftentimes we have very repetitive questions. So you may have that, different doctors are asking similar questions to really understand, was this an injury? How did the injury happen? Exactly the timing of it, treatment at home, all those sorts of things. And then lastly, in terms of the providers in the ER, I think one thing to keep in mind is that the care team, given the demands in the ER, may not have had a chance to look through your actual medical record. So very different than, I have clinic every Monday where I'm ahead of time looking through my patient's charts, looking through, what other doctors have they seen since they last saw us? When did they call our treatment center, reading those phone notes that we've had in terms of triage with the nurses. So in the outpatient setting, when you're going to your clinic checkup, again, we have the luxury of being able to look at records in our own system, depending on the type of medical record, electronic medical record. We can see times that care was given at an outside facility and read those records. But just know, in the emergency room, sometimes that's not the case. And so that's, the frame around which I want to kind of talk about, well, how do you best, tell your story? And sometimes that's with, just making the assumption that the team really hasn't had a chance to take a really deep dive through your chart. So then, in terms of the medical record, so the medical record, in this day and age, we would love if this was not the case, but not all medical records, unfortunately, really are connected. So Epic is one of the electronic medical record systems that is most widely used here in the US. That's what we have here at our center in Milwaukee, but is a platform that's different than I utilized in my training in Pittsburgh. Epic systems do have a way to talk to each other and one another. So we use something that's called the Care Everywhere feature. You would think everything gets loaded into one kind of nice streamlined story, but unfortunately it doesn't. One little clue for those of you that have my chart, that's an Epic system. So that might be a clue that your hospital is using Epic. And then the other piece, just in terms of that, thought on the window into the emergency department, is that the view of information in the ER may be different than what I'm doing when I'm caring for a patient in clinic. And so the views may be different. The way that clinicians are able to access the information may actually be slightly different. Now, thinking about, again, that behind the scenes aspect of the pharmacy and medications for the ER. So I think this is where every hospital is going to be different. So some of the key questions, I think, are really, does the pharmacy have the medication that you or your loved one needs to treat a bleeding event. This may or may not be the case, as well as how quick we can expect medications to come up from the pharmacy. Typically, we ask when I'm calling a patient into the emergency department, which we'll talk about that later, typically we're saying we want these medications right away so that they are, ordered stat through the system. Another key question is, do you have a product to treat bleeds from a home supply? And if you're bringing product to an emergency room, questions to ask would be, has the nurse ever mixed factor previously? And if not, or even if they have, it's likely been a while. And so some of those questions are, meant to really facilitate quickest access to medications. So even asking, are you able to assist in mixing the medication? For all of you that are very, savvy in terms of your treatment, again, this is where, I've seen it actually a couple of times before where, appropriately, if the nurse hasn't mixed in a really long time, they're getting out the whole big package insert. So that big piece of paper that unfolds from the vials and looking through that, which is obviously very different than what patients and families are doing routinely at home when they're utilizing a medicine that they use all the time to prevent bleeds. So now switching gears a little bit, let's kind of talk through ways that we can think about empowerment as really the way to navigate some of the obstacles that will be faced by patients with hemophilia and inhibitors. So I think first and foremost is the idea that your knowledge of your bleeding disorder or your loved one's bleeding disorder is power. So I think really empowering all of you to share your knowledge of your own medical story to optimize treatment. Again, thinking about one of those first behind the scene looks in terms of who's in the emergency department, remembering that hemophilia is a rare disease and having hemophilia with an inhibitor is even more rare. So again, the likelihood that this is something that your care team in the emergency department is quite familiar with is likely small. So the idea that you or your loved one is likely to be the most educated in the room can be really scary. But I think the way that I like to, tell my patients and family, like, this is scary, but it's also okay. And some of my job with my own patients, or, some of what I'm wanting to share today as part of the webinar is, how do you tell your story to make sure that you're getting the care that you need. So this is where I like to have some of this be something we can practice. So how do you really concisely tell your hemophilia story? So on this slide and the next, we're going to go through, in my mind, what are some of the kind of nuts and bolts of what you would need to know about yourself and then to be able to convey to the care team. So first and foremost is diagnosis. So an example of this is, I have severe hemophilia in A with an active inhibitor. Then including your usual treatment. So for example, I'm on emicizumab for bleed control. Then thinking about your bleed treatment, which I kind of called into, I put this example here by intention, knowing that someone with emicizumab is using that, or Hemlibra, for prevention of bleeds, but that's not the same of what you would be utilizing to treat a bleed. So then being able to concisely tell the story of your bleed treatment. An example of that would be, I need Novo-7, an IV medication when I have a bleed. And then also being able to vocalize who your care team is. So who is the team? Who should the ER reach out to help with your decision-making and your care? An example of this would be, Dr. Malik is my hemophilia doctor and will want to help. So really, telling that story, diagnosis, what's my usual treatment, what's my bleed treatment, and who is my care team. Then telling your story in the ER. So we had kind of those first, I think of those as kind of the background information about your hemophilia story. So in addition to that, you're wanting to tell the story, what I'm considering your ER story, kind of why you landed here in the emergency department and what are the most important things to know. And so, in addition to that prior information, we want you to be able to add a concise story around your bleed or your injury. And so some of the key aspects for me are location. So what's the location of the injury? And I think it's important to, include if this is a specific problem area for you or the person you're caring for. So what do I mean by that? Is this a target joint that's having another bleed? Is this a site that you've had a prior injury? Those sorts of things. So I included as an example, after you would have told those first aspects of your, again, diagnosis, your regular treatment, your bleed treatment, your care team, something to the effect of I'm having hip pain, which is same as the last time that I had a muscle bleed. So this could be, hip pain related to an iliopsoas bleed. Besides the location of injury, really thinking about mechanism of injury. So you want to include details around injury, especially if we had injury to the head, neck, abdomen, where this could be associated with bleeding on the inside that we can't see on the outside. So for example, here, my son fell down 5 carpeted stairs, but struck his head at the bottom of the stair landing. Your emergency department team is probably going to ask you a lot about, is this witnessed, meaning with someone around? Is there any concern that that there was loss of consciousness? Those sorts of things. So there'll be follow-up questions, but again, really being able to focus on location and mechanism of injury. And then the other piece would be any treatment that you've done so far. So, and we'll go through some of this as well, but with the concept, factor first. So really quick access to treatment is always our aim in the setting of a bleed, being able to tell the story of, you are on emicizumab and you gave yourself a dose of Novo-7 at home, specifics around, what medicine that you used, what medicine that you used and, the dose that you gave and the time that you gave it. So those are kind of some of the key aspects to, talk about with your ER team. So that's some of, again, kind of that empowerment. Now let's talk about some of the added things that you can do in terms of preparation to actually be in the emergency department. So one of the things that is, really a gold standard is patients having an ER card, and this could be electronic, as well as treatment or travel letters. So in terms of ER cards, this is, something that we still often do as a paper card that's updated and is patient specific. This is something that you can keep in your wallet or your purse, or that you can upload electronically to your phone as an electronic copy, which really has the basics of your diagnosis. So hemophilia with an active inhibitor, your treatment essentials. So you get Novo-7, you get FIBA, or if you've had a tolerized inhibitor, maybe you're getting factor prophylaxis, as well as how to call your hemophilia treatment center and outlining who your provider is. So for our patients, this would have my information and information on how to call our center. The other piece that I think is really important, we want our patients to be able to travel and to enjoy vacations or travel out of town for work. Sometimes this means that they are also traveling internationally. So as a gold standard, we also want patients to have travel letters. What's a travel letter is really has some more in-depth detail on some of the aspects of your diagnosis and treatment. So ideally think of this as kind of more of a script. So similar to if you've had, access to some of your letters from clinic, that that more kind of meaty detail on what is the story with your treatment. So we always include, when we're writing travel letters, the patient's diagnosis as well as their latest inhibitor level. For patients that have inhibitors, we're surveilling them at least once a year, if not more frequently. Then treatment options. And I think this is important in terms of what options would be to treat a bleed. Again, the specifics around what is the product, what is the dose, how often we can give the dose. Our travel letters also include aspects of the need to travel with product in your carry-on luggage. So remember, we don't want, especially if you're traveling internationally, we don't want your luggage to be lost and all of your product to be on board. And it may, potentially be days before you have access to your medications. And then the travel letters also contain information on how to call your hemophilia treatment center and identify who your provider is. The other thing that I like to talk about is really having a go bag. So a go bag is kind of what it sounds like. So this would be something that is ready to go. You don't have to pack. Really, it's there in the event of emergency. You can just scoop it out and walk out the door. Sometimes different individuals keep these in their car or they keep them at home. So what could and should be in your go bag? This isn't meant to be a fully exhaustive list, but in terms of things that could be and should be in the go bag, kind of at minimum, would include important paperwork. So again, that travel letter from your hemophilia treatment center or ER letter, a copy of your insurance card, some of the aspects around your emergency care guide, and an emergency contact form. I think it's important, unfortunately, it's never an ideal time to end up in the ER. So either if it's you with your own kids or if your child has hemophilia, some kids items. So books, small toys, a comfort item, bubbles, those sorts of things that can distract and help with deep breathing. So things that you can utilize when you're in the emergency department. Then an empty Ziploc bag for your factor. Obviously, we don't want you to be storing your factor in this bag, but this would be, ready. You're not searching around for the Ziploc bag and you can just, pop your factor in along with a ice pack kind of as you're leaving the house. A cell phone charger. This one's key. I will say that's where when you're wanting to update your spouse, those sorts of things, having a phone charger so you don't run out of battery when you're in the emergency department. And then another Ziploc bag that's already stocked with everything you would need for an infusion. So again, think about this as you're ready to go. This is the bag that you have that you can just pick up and head out the door with. Now, in this last section, I want to go through some of the aspects of what I think is an ideal way to kind of go through what would be a really optimal way for you to be in contact with your hemophilia treatment center, your care providers, and how do we think about this in kind of a kind of multiple steps. So the first thing I would say is kind of wrapping the frame around you call, meaning you as a patient call, we call, meaning we as your treatment team call, and then they call, meaning the emergency department team calls back. And so it's meant to be really kind of wraparound communication, and we'll go through what that really means. So you call. So I have a picture of a pager here. I actually have my, pager here on my desk. We're like the only people in 2022 that still carry pagers. This is meant to be a tool so that you can reach your team at all times. So, the you call piece is a reminder that your hemophilia treatment center is always going to have a provider of some sort on call. Sometimes this is the nurse that takes the first call. Sometimes it's the doctor. Sometimes it's a nurse practitioner or physician's assistant. It will depend on, the specifics of your center. As part of call, they typically have electronic access to your chart. So I mentioned here in Milwaukee at our center, we use Epic. So I have, a secure Epic app that's on my phone, as well as ability to remote in if I'm at home. And what we would want you to do with the doc that you're calling, or the clinician that you're calling, is really similar to prior slides. We want you to tell your story. So fantastic if you can call and say, again, I'm a 25-year-old patient who has severe hemophilia A with inhibitor. I'm on emicizumab prophylaxis. I need to treat bleeds with Novo-7, and I'm Dr. Malik's patient. So being able to kind of say that that one-liner. And then it's important for you to remind your care team kind of where you are. So let them know which hospital you intend to go to, or have them help you look up a hospital. So especially if you were, let's say visiting relatives out of state, or you were on a camping trip or something like that, I pull up Google and look up hospitals to figure out what would be the closest, place for someone to go. So after the you call then becomes the we call. So meaning after your hemophilia treatment center has discussed your need to go to the ER with you. So we've decided, based on the story of what had happened, or based on your symptoms, I really do think it's important that you're going to go to the emergency room, because we do need to get a CT scan of the head, whatever it may be. So really, after the hemophilia treatment center team has discussed the need to go to the ER with you, then they will call the ER that you're going to. So this is, again, the we call. So every hospital does a little bit differently. Sometimes I'm giving that sign out to a doctor, sometimes a nurse, but really I would be conveying information regarding your diagnosis. Again, that similar background information, the injury or the bleed, and then what the plan of care is. So I would give the emergency department the nuts and bolts about the treatment. In terms of, the example that I shared earlier, this is someone, this is a 5-year-old with severe hemophilia A and an inhibitor that fell down the stairs. There was no loss of consciousness. They're on their way to the emergency department, by car. They're approximately 20 minutes away. Mom accessed his Metaport and gave a dose of Novo-7. I'm going to want a head CT on arrival. Some of those type of, examples where you're helping the emergency department, who again may not have familiarity with patients with hemophilia, really guide their care in terms of what you think is the best plan. I think really importantly, this ideally helps facilitate the plan of care. So in most systems, what it does is it creates a pre-arrival. So I mentioned in that triage step, that if you're showing up to the emergency department and kind of no one has called ahead, they're initially putting you into the computer. If your care team has called ahead, then you're they're typically creating what's called a pre-arrival visit. This is a visit where if you didn't go to the ER, you're never going to be billed for it, but it's more a mechanism in the emergency room that they have noted that a care provider has called in and told your story. I think the other part that helps with some of the we call is it helps decide on admission, next day follow-up. So really, helps in terms of streamline what are some of those aspects of what are the likely care needs. And then last but not least, in that you call, we call, they call. So the they call piece, I think, is really important. If you ask me what gets missed the most, it's this. Where they call, we would be asking the ER to call your hemophilia treatment team prior to discharge. And that's where I typically am saying, oh, and please call me back after my patient's been there and they've had their head CT, they've had a chance to get their medicine, call me back so we can discuss the next plan. Feel free to, feel empowered to ask, have you had a chance to reach back out to the doctor on call about my care? I think this is really important because sometimes the story is different compared to what was going on at home versus in the emergency department. And I think it ensures the hemophilia treatment center team has really all the information needed to make treatment recommendations. So, what were the vital signs? What were some of the labs? Those sorts of things, what are the essentials that we would need in order to make a decision? It ensures the care in the ER is what we recommended. So if we did need x-rays, CT scans, again, I'm always saying factor first, but what I don't want to hear is if there was enough mechanism of injury, so kind of how the injury happened, that I do think we need a head CT. What I don't like to hear is like, oh, they seemed fine on the outside. So again, really being able to speak to the fact that patients can look okay on the outside, but that doesn't fully rule out that there could be bleeding on the inside and that these are scans that we want to get. And then importantly, I think it helps facilitate next day care. Again, every hemophilia treatment center is going to do things a little bit differently. Here in Milwaukee, we have communication that's really truly ongoing. That's some of what I love about being part of a hemophilia treatment center team, so that patients that we talk to today on Wednesday, we typically follow up on Thursday, or if they were in the emergency room overnight, we have a way that we send electronic communication, and then the next day, primarily the nurses are reaching out to the patient or their family to get an update on how they're doing. Thankfully, the majority of the time when people are doing well, they got the treatment that they needed, then there may not be anything else to do other than, resume the normal prophylaxis. That being said, sometimes symptoms were better, but now they've gotten worse, or there's something new that has come up. And so, that helps me decide, is there any different imaging we would want to do? Is there a reason that I want to try to see this patient in my clinic this week if possible? So really, again, helps with some of that aspect of making the care ideal. Now, specific to kind of after ER follow-up, again, we've gone through some of this already, but really those next day follow-up, I think, I want to empower you also to make sure that this is something that, you can expect as really a best practice with your care team. So, to discuss with your hemophilia treatment center team, any need for ongoing medications or other studies, to discuss return to work or school. I didn't put in there specifics of return to activities, but especially if there's been an injury, maybe this is also a return to, being active, and then making a clear plan on when your next clinical follow-up will be. Is this, again, a time, if you were going to be coming to clinic to see me in 6 months, that I think it's fine that we wait 6 months, or should we try to sneak in a visit before then to really check up? So the other aspect that I like to think about that is, less all the specifics of just the medicine and the nitty gritty on, okay, the bruise was this size, now it's this size. But I think this also gives you and your care team, a platform in which you should feel some empowerment to speak up. So really kind of what went well. These are scary times to go to the emergency department for you or your loved one when you're injured, but to really think, okay, what parts went well? And then also to think about kind of what didn't go well. So what didn't, what was a hiccup that happened? Is that something that I can help as the medical director of our clinic, communicate with the leadership of the ER? So really, the ER does want to do a great job. They have different pressures than I do as someone who's not an emergency department doctor. So really thinking about how do you pair together to, to make things optimal. And I think, always you can ask your hemophilia treatment center staff to follow up with a local ER for feedback. So this is where we have an awesome nurse manager. She is someone that, really partners with me. If we had, again, I think for us, oftentimes what's missed is that they call. So, you call, we call, they call, meaning they've given us full sign out. There's times where things have not maybe gone as smoothly as they can, where our nurse manager is often, reaching out to the nurse manager of the ER to just talk about, okay, this is a patient that if they seek local care would be coming to your emergency department. So let's think about how to make things even better for the future. And, thankfully most people in healthcare really do want what's best for patients. And so, we have found that partnership is actually typically something that is welcomed. And then I think as a last bullet point, at any institution, there's always going to be a patient relations group is what we call them here. It might be called something slightly different at different places, but this is meant to be kind of a neutral party. So if you've had issues with a visit to an emergency department, consider the need to speaking to patient relations at that hospital. So just provide them feedback of, some of the aspects of the care that didn't go well when it is something that you think was, ultimately impacting the outcome. And that's really all that I have in terms of kind of the outline. We are meaning to then use the rest of the time to be able to do some question and answers. So thanks everybody for your attention.
That was great. Thank you so much. If you have any questions, please feel free to throw them in the Q&A portion or in the chat. We also have 2 little questions for the poll for you today. If you can go ahead and answer those while we get started. I'm going to start with a question that came in from Kyle on YouTube. Kyle says, I've always wanted to ask this in case of emergency. Suppose I am on prophylaxis treatment on AHF brand A. During emergency, I get treated with AHF brand B, both recombinant. Will this cause an issue, especially if different brands are injected within 24 to 30 hours of the first dose?
Yeah, that's a great question. And I think the answer to that is it's likely okay. I think we don't have, as a physician, I love when there is a well-designed research study that has specifically looked at this answer, or this question, I should say, to provide an answer. This is one of those times where, I think this hasn't been done specifically. There's been a lot of monitoring as a class, what we call the EHLs, the extended half-life products. With all of those drugs coming to market, there really was intense scrutiny of, is there any patients that newly develop inhibitors on those products, and that wasn't something that we saw. So typically, the way that I tell my patients in terms of if they're getting treated with a different product, is that it's likely okay. There's no data to say that it's, clearly dangerous. For those of you that have a tolerized inhibitor, there's not strong data that would make the inhibitor come back. So I think focusing on treating the bleed in that setting is really the most important aspect.
Thank you. So what would be the biggest takeaway you would want the audience to walk away with from your talk today?
Yeah, I think, practice, and honestly, this going to sound kind of nerdy, but like practicing out loud, being able to tell your story is something that's really important. And, it's stressful when you're sick or your loved one is sick. And so, maybe it's okay that is written down and you're kind of reading from it. So I think that would be one key takeaway, is like really empowering you to know I have to be the one to tell the story. And then if I can sneak in a kind of sub bullet point on that, that piece of telling your story is also, relying on your hemophilia treatment center, even if they're not open, as the on-call team to help optimize, the care that you would be getting when going to the ER, so that, you call, we call, they call, set up.
Great. Let's see. As a quick recap, what should we bring into the ER with us so we can be better prepared?
Yeah, so I think let's focus a little bit on product. So this is where every scenario is a little bit different. The way that we do things here in Wisconsin was similar to what happened in the area of Pennsylvania that I was in, where patients were allowed to utilize a home product in an emergency setting, emergency room setting, if there wasn't ready access to that product. So I think that is, kind of one key is really thinking about bringing product to the emergency department so you can be treated. Here, when, my office is part of a medical campus here. And so when our patients come to our adult health hospital or our peds hospital, those medicines are coming from the pharmacy. But, that's one important aspect of your arrival. And then recapping kind of that go bag, info on your diagnosis, that travel letter, your product, if you are going to be using it, your supplies that you would need start to finish to be able to do an infusion. And then some of the other aspects are just, knowing that even when things are an emergency, start to finish, you spend a lot of time in the ER. So some of those, a phone charger for you as a grown-up, and then some of the aspects of things to keep you as a parent, or if you're needing to bring your kids there to keep them entertained.
Thank you. We have a comment from the Q&A. It's incredibly beneficial to have a printout with all medications and conditions that can be given to EMS if the patient goes by ambulance.
Yeah, I would totally agree with that. Because I think, yes, that's a great call out. Because I think, remember, the EMS isn't going to be, and I said I can access Epic on my phone or by, logging in remotely, that's something that, EMS isn't going to have. So I totally agree. That would be a great thing to have, not just specific to your hemophilia.
Fantastic. Thank you. Do you have any thoughts or opinions that you would tell a new parent with a child that has a bleeding disorder to prepare for the emergency room? I know you kind of covered it a little bit, but just for any new parents.
Yeah, I mean, I think, some of it is, and I'm a parent of two little girls that don't have a bleeding disorder. And in the times that I've taken them to the emergency department, even though I'm a physician, it was stressful for me. So I think, one of the most important things is giving yourself grace that this is stressful, and that in part of being a parent and caring for, a child with a bleeding disorder it is stressful, and giving yourself, grace to know that you really are doing the best that you can in that setting, I think is really important. I think, a lot of the frame, when I talked about kind of telling the story, was in light of maybe you as the patient saying that, but I would want the same thing, from a parent to really be able to say, this is my son, he has severe hemophilia A, he's on regular treatment or prophylaxis with this medication, this is what we need to treat a bleed. I think those are really important pieces. And then, again, kind of that concept of factor first. So, we don't want to delay treatment in order to get a head CT or an X-ray or those sorts of things. And so I work, even this week, looking at, okay, all the orders were placed at the same time. Do we think there was any delay because the patient did get a head CT before they got factor, really kind of those deep dive pieces. So I think, heading into the ER, just being able to advocate the best that you can, and know that your care team does want to help. They are, there to back you up and to help navigate a stressful situation.
That sounds great. Thank you. I actually don't have any more questions right now, but if anyone has anything else that they would like to ask, you're more than welcome to throw it in the Q&A or comment on whatever platform you're streaming on. We'll give it just a moment before we say our goodbyes. Jessica commented, great presentation, and I agree. That was fantastic.
Thank you.
Okay. Well, I would like to thank you one more time, Dr. Malik, for taking the time to join us this afternoon. We appreciate your time and expertise. I would also like to thank each one of our viewers for joining us. Please note that this recorded webinar will be available on Friday, September 30th at hemophilia.org under the events tab with all of our archived webinars. Also available in the events tab is our upcoming schedule for our weekly Wednesday webinar series. Thank you for joining us this afternoon. I hope everyone has a wonderful week.
All right. Bye, everybody.
Thank you.